Now, Bppv is the most common vestibular disorder across the lifespan, and the onset occurs most commonly in the 5th to 7th decade of life. It is estimated that 9% of elderly patients undergoing a comprehensive geriatric assessment for non-balance related complaints have unrecognized Bppv. So what the study shows is that at least 9% of seniors live with Bppv unnecessarily. Now, Bppv is most common in seniors, but occurs in younger people most often after whiplash, concussion, or inner ear infection. The sad thing is, it costs approximately $2,000 to diagnose, as over 65% of patients undergo unnecessary diagnostic testing. And that is a big reason why we made this course. When a patient has Bppv, they typically complain of symptoms that last for seconds, maybe even minutes. The symptoms may be vertigo, lightheadedness, nausea, a sense of imbalance, motion sensitivity, maybe any of these things. It doesn't have to be all of them. And the things that provoke it are positional changes, such as lying down, looking up, bending forward, and rolling over in bed. So with Bppv or any other form of dizziness, to tease out what the possible cause could be, you always want to look at tempo, symptoms, and circumstance. Now, tempo, does it last seconds, minutes, hours, days? Is it a recurring problem? And with symptoms, is it vertigo, is it non-vertigo? Is there other ear symptoms like ear pain, pressure, ringing in the ear, hearing loss? Or is there neurological problems such as double vision, slurred speech, choking on foods, legs collapsing out from underneath, such as drop attacks? And what causes it, or what are the circumstances to provoke the symptoms? Is it positional changes? Is it head motion? Is it eye motion? Is it come on spontaneously? Or does it come on with certain social interactions? So if you can kind of tease out the tempo, symptoms, and circumstance, it'll help you differentiate what the possible cause of dizziness is. And with Bppv, the symptoms last for seconds to minutes. They may or may not complain of vertigo, and things that typically provoke it are activities such as lying down, looking up, bending forward, and rolling over in bed. So with Bppv, there's two types. There's Canalothiasis and Cupulolithiasis, both tongue twisters. With Canalothiasis, the best theory goes back to 1992 with Epley to explain Bppv, where otoconia float freely in the endolymph of the semicircular canals, and 85 to 90% majority of the time it's the posterior semicircular canal. When the head is moved, the otoconia move to the most dependent position in the canal. And the movement of the otoconia will cause movement of the endolymph. The movement of the endolymph in turn pushes the cupula, causing vertigo and nystagmus. Now, nystagmus is that abnormal eye movement, and we'll show you some examples of that later. The vertigo and nystagmus is typically delayed several seconds. Once the otoconia stops moving, the cupula returns to its resting position. The vertigo and the nystagmus stop, and that typically is within a minute. So just a review of the anatomy, we have our outer ear, our middle ear, and our inner ear. And the inner ear has 3 semicircular canals, and then there's 2 otolithic organs, being the utricle and the saccule. And the otolithic organs have otoconia packed on the outside of them that are gravity sensitive, and sometimes these otoconia break off, and it's normal. Just like your hair breaks off, your skin breaks off, the body's always replacing itself. These crystals can break off, and they usually trickle down to the bottom, and over time your body will absorb it. But if they break off and your head is tilted back and turned to the side, the crystals can get funneled into one of the semicircular canals. Most commonly it's the posterior semicircular canal. And when you sit up, the crystals float to the bottom of the semicircular canal, so they're stuck kind of like in a P-trap. So in this diagram, actually the diagram on the left, you can see the otoconia at the bottom. And then if we tilt our head clockwise, you'll see the otoconia will fall to the most dependent position. And that'll cause the endolymph to flow in a counterclockwise manner and deflect the cupula downward. And if the cupula is deflected, that'll affect the firing rate of the vestibular nerve. And then once the otoconia settle to the bottom, the indolent flow will stop and the cupula will return to its resting position. Now with Canalothiasis, there's an older theory that goes back to 1969 to explain Bppv, where otoconia adhere to the outer surface of the cupula of the affected semicircular canal. Given the increased density of the cupula, it now becomes gravity sensitive, and changes of the head position cause the cupula to be pushed or pulled due to this increased density. So looking at the diagram on the left, you can see that the otoconia are stuck on the cupula on the canal side. And then on the diagram on the right, you can see that the otoconia are stuck on the cupula in the vestibule side. Then when you turn your head, or the canal gets turned clockwise, you can see with both examples, the cupula will deflect down given the weight of the otoconia, and that'll affect the firing rate of the vestibular nerve. So the deflection of the cupula causes immediate vertigo and nystagmus that typically lasts over 1 minute. Canalothiasis is less common than canalothiasis, and much of the early research focused on its treatment. If you look back, a lot of the early treatment for Bppv was more liberatory maneuvers, where we had people moving suddenly to try to break those crystals off. Back to this diagram where we see the otoconia are attached to the cupula. The diagram on the left is on the canal side. So if those otoconia break off, whether with time or a sudden head motion, now the Canalothiasis has turned into a canalothiasis and still needs treatment in that regard. Whereas with the diagram on the right, the otoconia are adhered to the cupula on the vestibule side, and if they break off, there's really no need for further treatment. So here's a cheat sheet contrasting canalothiasis to Canalothiasis. So on the left, we have latency of onset and duration. So canalothiasis, after you change the position, it usually takes over a second before there's an onset of vertigo and nystagmus. And with Canalothiasis, it's sudden. There's not that delay. And the duration of canalothiasis is typically less than a minute, whereas with Canalothiasis, it's over a minute. Some things to note: that the nystagmus depends on the canal involved in both conditions, and the intensity of the nystagmus with vertigo decreases with repeat positioning with both conditions. So if you keep doing the test to check for Bppv, with repeat testing over a short period of time, the nystagmus will be less noticeable. On the previous slide, we mentioned how the nystagmus depends on the canal involved with both conditions. So here's an outline of what you'd see with each canal. So if the right posterior canal is involved, you'll see upbeat right torsional. If the right anterior canal is involved, you'll see downbeat right torsional. If the left posterior canal is involved, you see upbeat left torsional. And if it's the left anterior canal, you'll see downbeat left torsional nystagmus. If it is Bppv affecting the horizontal canal in either ear, you'll see either agiotropic or geotropic nystagmus. Really what that is predominantly lateral nystagmus. Agiotropic means that it's beating away from the ground. So if someone is laying on their back and they turn to the right side is against the ground. Agiotropic would be left beat nystagmus. Whereas when someone turns to the right side is closer to the ground and we see right beat nystagmus, that's geotropic nystagmus. And with geotropic nystagmus, with the horizontal canal, that's typical of canalothiasis. And if we see agiotropic nystagmus, that's indicative of Canalothiasis.